Welcome to the EMT Pro podcast, where we deliver relevant content from the field and the classroom each month. Episodes of this podcast can get you 1 full hour of CE through our partner, emt-ce.com. So head over there for more information. I'm your host, Steve Williams. With me today, Dan and Holly. Guys,
Hi,
hello.
Steve.
Welcome. How are you guys doing?
Great, Steve.
Yeah. You're so excited
I
about who we
am.
have as a guest today.
Coffee's all done.
Yeah.
It's sunny.
It's sunny. We got a great guest today.
Dan has been man-crushing on our guest today. They've been having a great conversation prior to recording, and that's Kyle, who we'll introduce here. You can hear him laughing in the background.
Kyle, the golden retriever.
Yes. Kyle, why don't you, first off, welcome to the show, man. Happy to have you.
Thank you. I'm so stoked.
I've known Kyle professionally and as a friend for a few years now, and excited to have him on today to talk to us about a case study, a specific MCI, MPS type call. But give the listeners kind of some of your background and how you got into EMS, and we'll kind of go from there.
Okay. Yeah. Hi, everybody. My name is Kyle Snider.
Hi, Kyle.
Hi. We'll say, okay, so I'll start and say that I got into EMS, fire and EMS, we'll say like pre-hospital medicine in general, in an attempt to gain clinical hours to be a PA. And how I sort of describe the mental transition from wanting to be a PA to becoming a paramedic is I was desperately derailed, mostly by you, Lieutenant Steve Williams, and the crew on Medic Unit 122 out of Station 2. So I began my time in EMS as functionally a firefighter EMT intern or live-in volunteer at Corvallis Fire Department, and really kind of cut my teeth from a BLS standpoint on ALS ambulances there while I was going to Oregon State University. I had got my bachelor's degree in human biology, ended up moving to Montana to follow my then girlfriend, now wife, while she was doing grad work at Montana State University, and worked more rural agencies, both single role EMS only, and also dual role fire in EMS over there a bunch. Kind of got an idea of what I was looking for in terms of a career, and also realized, hey, if you want to be as involved as possible in this field, you're going to have to become a paramedic. And so I realized, hey, yeah, I'm going to have to go to school. Went to school doing a hybrid remote program. That's National Medical Education and Training Center. Can't recommend them enough as a medic school and medic program, with people who are actively trying to figure out where they're going to live in the world. Started school with them, moved back to the West Coast, worked at a few agencies, and have now found myself pretty well implanted at a very rural county service in the Northwest, working both as a 911 and critical care transport medic, single role for a county system in an extremely large county with very minimal pre-hospital resources. So I kind of call it the Wild West where I work. I don't live where I work, and so I actually live in kind of a more urban area, but I drive over to the county, and I've been kind of cutting my teeth as a medic over there with very much extended pre-hospital transport times, as well as being sort of moved into a critical care role even before I even fully knew what that was. And so, yeah, that's me, and I'll stop it right there.
Wow. You know, I was thinking through that entire thing you just shared, you sound so less desperate when you mention to people that you moved to Montana to follow your girlfriend, who's now your wife. You know what I mean?
Yes. Yeah.
I didn't make a stupid decision. I
great.
promise it was worth it.
yes. Well, and as you remember, LT, it was quite like a challenging decision at the time, right? I'm
remember
like,
that, yeah.
oh man, there's so many interesting facets to life. And so, but yes, no, the gamble was a great one. It wasn't a huge gamble, but and so it has since worked out well. Yeah.
Yeah. I just remembered that crew that you spoke so fondly of. I don't think they were invited to the wedding.
The plot thickens.
I wondered if that was going to come up.
Oh, wow.
I don't have many regrets in my life, but that is one of them. Okay.
Well,
I will say that.
don't regret it. I remember after I got
He
married.
wouldn't have come anyway.
Right.
Yeah, exactly. You probably would have had some weird remote wedding, and I wouldn't have wanted to drive out there anymore. No, but
We did. It was. Yeah.
I remember after we got married. This is completely unrelated to EMS, but whatever. I just remember thinking, I'm never going to give anyone crap for how they choose to invite or not invite people anymore, because it was such. Even though
Not
we
easy.
invited a lot of people, there were still people that were just like completely
Forgotten.
pissed off for
Yeah.
whatever reason,
Yeah.
and it's like whatever. It's their day. Let people do whatever they want. Anywho,
Right.
Well, shoot, man, I'm excited to talk to you about this call that we've got, because I don't know that we've talked about
MCS? No.
MCI or
Yeah.
MPS
We've had
calls.
I think we talked about just a couple. When we did our trauma, I think we did
Did
a
we?
little MCI, but nothing
Yeah, nothing.
specific.
Yeah, but then again, I can't exactly remember all the stuff we've talked about. To be honest.
So what exactly is the definition?
Old Lieutenant Stephen Williams.
Yeah, pushing 40. Yeah.
Yeah.
What were you gonna say?
What exactly is the definition? Because it used to be MCI, MPS,
Yeah.
and those, I think it was 9 or less was an MPS,
Mm-hmm.
10 or
Multiple patient
more,
scene.
right,
Yeah.
was an MCI.
Maybe
Yeah.
that's because we sort of grew up in more of a metropolitan area,
Probably.
and MCI would be 10 or more patients,
Mhm.
mass casualty incident. But Steve, you were saying that it has to do more with resources than
Yeah.
number of patients.
That's what I remembered learning in school, but I don't know that there's. I think the definition is kind of subjective. If you have, the example that came to mind was there's some areas here in Oregon that have a one medic, one basic response for car wrecks, and so
Right.
you might get a volunteer fire department out in the middle of nowhere with your response, but you're going to get an ambulance. And if that one person or two person crew shows up and there's 5 patients, that's probably an MCI for that crew,
Mm-hmm.
because it's out of, it's tapped out their resources, right?
Yeah.
Especially if you have 5 critical patients, right?
even
MPS would
just
be,
one.
yeah, right? I mean, MPS would be you have the resources to handle the call. It's just multiple patient scenario, multiple patient scene. And then an MCI is when it's tapped out your resources, is what I remember.
Interesting. Does that track for you, Kyle, in your area?
I was going to say that's exactly so. I mean, due to the extremely, and this will be highlighted, well in the call that I go over today. But yeah, that's exactly correct. Is I've always learned that it was totally relative to the system's resources, and if it kind of exacerbates or if the load workload on scene is not immediately accomplishable or relatively accomplishable by the system, that it becomes MCI. And that's pretty much exactly what happened with us. And it's a 5-patient scene today. And it was like firmly an MCI, not only for the system, but for the hospital as well. So, yeah.
Oh, I bet.
Nice. One thing I do want to just double check before, so I can ask you the right questions or at least share the right information with listeners as we proceed through the call. Do you guys use at your agency, do you use the START triage model, or do you use something else?
We do. It was not almost at all utilized in this call, but
Okay.
yeah, that is going to be our written protocol as of now, which has since changed. We're 2 protocol sets improved since this scene.
Mhm.
But yes, currently we do use the START. I would not bank on it being a shining example of the START triage model in the rundown today.
Sure.
But we have used that as a debrief tool for this call
Sure.
in the past. So,
Awesome.
yeah.
I think the other thing to make mention of is, while I'm sure, and I don't even know the details of what you're about to share, but you have shared some high-level stuff with me that a lot of things didn't go well. Those are the ones we learned
Mhm.
from the most. And I know early on in this podcast, Dan was bringing some pretty regular case studies for us to go over, and a lot of them you were on, and you were specifically bringing up the ones where you thought the biggest mistakes were made so that people could learn from them.
Right.
Mm-hmm.
And that's the approach we're taking today. We'll continue to take as a podcast for sure. And
Awesome.
so
Can
we're
you
not here to demonize anybody.
run down the START
Cool.
triage model? What
Yeah.
does it stand for?
So START stands for Simple, Triage, and Rapid Treatment. You basically are, and there's all sorts of kits you can buy to outfit your ambulance with this stuff, but you're basically looking at three things: respiration, perfusion, and mental status. The RPM model is kind of how I remembered it. You have 4 colors of triage. There's green, which is minor. Basically, delayed care can delay up to 3 hours or so. Your yellow is your delayed patients. That's urgent care, and you can delay treatment for up to an hour with these. And this is general, right? I mean,
Of course, yeah.
right. And then red is immediate. So they need immediate care. They have life-threatening injuries. And then black is dead. The victim is deceased, and there is no care required. So that's the high-level look at it. But, well, you know what? Let's go over the RPM part. Patients with breathing rates that are greater than 30 per minute, talking about the respiration part, the R, those are tagged immediate. If the patient is breathing and the breathing rate is less than 30 per minute, you move on to circulation and mental status observations. But at over 30 is immediate.
Isn't it under? Is it under 6, under 10, or?
Yeah. So if the patient's not breathing and does not start to breathe with a simple airway maneuver, that's when they should be tagged deceased or black.
Copy.
So then the circulation is P, the perfusion. And the best way to do that is to check for a radial pulse, because we're obviously looking for total perfusion of the body as best as we can with our simple tools that we have. If the radial pulse is absent or irregular, the patient is tagged immediate. And if the radial pulse is present, you move on to the final observation of RPM, which is mental status. So with mental status, you say, open your eyes, close your eyes, squeeze my hand. And patients who can follow the simple commands, they have adequate breathing, adequate circulation. They're tagged delayed. A patient who's unresponsive or cannot follow this type of simple command is tagged red or immediate. And then, the whole goal that they like to say with the START triage is that it's used to find red patients.
Mm-hmm.
That's we want to separate those out from the yellows and the greens, because we have some time with yellow and greens. We don't have time with reds.
And what's your timeline on each encounter with a patient? Less than 30 seconds?
Yeah, I don't want to spend more than a minute with a patient.
Mm-hmm.
And that's kind of what I remember, Dan, this is probably back in your era, man. No offense. But do you remember that book that they would pass out in paramedic school called Sick or Not Sick?
Yes.
And it was basically training people to walk into a room and within 60 seconds determine if you were sick or not sick.
Right.
And that book kind of went away in my program. I remember it was on our reading list, and then we just never went over it.
It's a great book, though.
Yeah, I really liked it. And this is what it kind of reminded me of. START triage is kind of walking into a room and going, okay, do we have time to get some stuff done here, or do we need to load this patient up and just start heading to the hospital because we're already behind for whatever medical or trauma purpose we're there for?
I can only really think of one time that I can remember where I've ever had to utilize this system, mostly because I think a lot of places that we've all worked have multiple agencies on scene or multiple rigs coming. But I can really only think of one where it was just me and my partner and like 5 patients for like an hour. It's kind of terrifying.
Yeah. I've had one. I was not a paramedic. I was working as a basic on a 2-person ambulance with a paramedic partner, and we weren't quite as rural as Kyle's day-to-day stuff is, but it's a relatively rural area here in Oregon. And it was a 2-car head-on pickup truck versus a minivan. Minivan had a handful of migrant workers in it. Pickup truck had someone in the bed of the truck, kind of sitting in the back. 2 people up front. Anyways, there was somewhere like 7 or 8 patients, and we were the only ambulance. We called you guys, and Life Flight sent 2 helicopters. And I don't remember. There were 2 deceased. You guys took 2. We took 2. I can't remember what happened to the other 1 or 2 patients, but we might have had another rural agency that eventually got there an hour later or something and picked them up. But and to be honest, even then, I don't remember what we used to tag people, if we did.
If you even did.
Yeah. I kind of doubt we did, knowing the agency. But yeah, it's pretty rare, especially in our areas, that you do this, because especially in the Pacific Northwest, there's a lot of land. There's a decent amount of people, but there's a lot of land, and people aren't on top of each other like they are in metropolitan areas.
Yeah, and the tagging system is really for like, you do the tagging, and then the next person that comes along doesn't have to redo it. I don't know if I've ever been on a scene where like I've been tagging people for someone to follow behind.
Right.
We're just all like, that's red, that's green.
Yeah.
They can walk over there. I don't know. I mean, so it's really interesting. I'm really fascinated to hear what Kyle has to say.
Yeah. All right. So, Kyle, for this call, we will do our best to ask you questions and then let you answer them. And then if we're missing something, feel free to fill in the gaps. But
Okay.
why don't we start with, tell us who you were, the type of ambulance you were on, as far as how many people were on it, typical response in that area. And then let's start with what you were tapped out to.
Okay. Yeah. I recently went over this with a paramedic who just got hired in our system. I'm the kind of the lead field educator for the system right now. And so I thankfully was able to go over this call a few days ago, sort of in prep for this episode. However, it is still super complex and confusing and challenging for me to get the chronological order of things perfectly correct. So I will do my very best to just outline things succinctly. And yeah, please ask questions, because that will aid in the clarity and probably the flow of the call, as you all, and so, yeah, so I will start out. So this call, I ran 3 weeks out of paramedic school.
Oh my
and
goodness.
So, I was 3 weeks on this job. So I was 4 weeks out of medic school, but 3 weeks
then you have it then.
actually working. Yeah, right, exactly. Yeah, should be fine. And so in some ways, I think it was helpful, because a lot of this like book style knowledge was fresh in my head. And in other ways, a big part of me wishes I could redo the call right now, knowing kind of what I know now and the things I've gotten comfortable with. But either way, so setting the stage, I'm new to this system. I'm new to this area that is huge. It's larger than some states. And so what made it kind of challenging is the tones drop for a 3-vehicle MVC, approximately 45 minutes out of town where we're based, with at least 4 patients confirmed injuries. So they said at least. And so the problem with where I was when we received those tones is I was on actually kind of a critical overdose call at that moment. And so I just remember feeling particularly exacerbated because I'm trying to resuscitate this person that's overdosed, and we're actually in the process of transporting and dropping off at the hospital when this all occurred. And so a couple things happened. One, I was able to drop this patient off, give a really fast report, and then warn the only physician on duty in the emergency room that we were about to go out to this 3-vehicle MVC with at least four confirmed patients, which right away is grabbing everyone in the ER's attention.
Sure.
The other thing that occurred was while I was dropping that patient off, the only other ALS, the only other unit, and it just so happened to be ALS that day with another paramedic that was on, very rare at that time in our system to have 2 paramedics and 2 EMTs on at the time. They were able to go en route, essentially while I'm doing a patient handoff with the physician. And so we already have 1 ALS unit en route. Like I said, this is 45 minutes out of town. And we have at least 4 patients. And so it just so happens we have 4 ambulances at my service. And so that is what's dubbed an all-call in my system. And so anyone and everyone that works in the community that can respond is asked to do. How the system is sort of bolstered is we have minimal full-time shift-style staffing. And then it is sort of added to the staffing is added to by community members who have their emergency medical responder or emergency medical technician training, who are then able to, they're dubbed as reserves, volunteers, or casuals. They're kind of all interchangeably, used, or all of those names are interchangeably used. They are paid. So I think volunteer is the least accurate, but either way, who ended up being my partner as we were initially dispatched was a reserve EMT who came in from home. And so the paramedic who was on stole my partner as we pulled into the bay to drop off the patient that we had just treated. They go out and they're en route for about 10 minutes before we're able to go en route. Me and this partner that just came in from home. And then we actually have a 3rd ambulance that's able to come en route, or to go en route probably 25 minutes after we went en route, where community members were able to just kind of flock to the scene or to the hospital, and then take that 3rd ambulance out. So we have 2 ALS units and 1 BLS unit headed out to this scene, all spread out in terms of when they were able to go. So about 15 minutes into the response, in my unit, so there's a unit 10 minutes ahead of me, I'm 10 minutes behind them, about 15 minutes into my individual response, we get a patient update. There's in fact 5 patients. 1 is actively entrapped, 2 have self-extricated, and there was mixed information on the rest of the patient load. This also happened over almost 2 years ago, so I'm going to do my very best to make sure I'm being factual here.
Sure.
And so as we're going, I call for any rotor wing asset. We have multiple flight agencies that serve the area. They are relatively busy because our rural area is bordered by many other rural areas. And so we utilize flight a lot. And so we ended up getting 1 helicopter to accept the flight.
What was the weather
prior
like,
to
Kyle?
us even being on scene? It was clear. It was beautiful.
Yeah.
It was 75 and sunny. This was in the summer. So
Cool. What time of day?
Probably 2 p.m. Just
Okay.
after lunch.
Cool.
Yeah. So in terms of conditions and daylight, pretty great.
Mm-hmm.
All things considered. And so great. So I'm thinking we have 3 units, 2 ALS, 1 BLS, and a helo en route. So feeling okay about resources, other than the helicopter was a minimum of an hour away flight time. And like I said, we're 45 minutes one-way ground unit to the scene. And so The first unit gets there 10 minutes before us, and this is when the MCI sort of start triage somewhat begins. We get radio communication from the paramedic that's there saying, "Hey, I've got 1 red, 2 greens, and a yellow." And I'll rephrase the order there. We got 1 red, 1 yellow, and 2 greens. And so he says over the radio, we're gonna go ahead and start treating and loading up the red patient, and we'll leave the yellow and 2 greens for the units that are currently en route. And so I
wait,
copy. It sounds.
You said
Yeah,
five patients, but you only triaged
yes,
4.
Right. So that's a big that's like a, we'll say like a moderate to large contributor of like confusion and difficulty already starting.
Okay.
Pre-scene arrival. So
Now,
it's a little
do
bit of
you
some
have-
mistriage because he missed a patient. Yeah.
Do you have
No.
like a fire engine or something that can do extrication on the way too, or are you all in ambulances?
Good question. That's like such a good question, Holly, because so we are the only paid service in this county. So our ambulances carry rescue complement and extrication equipment. So
Nice.
my plan was to just use that and begin on that. That's that really important detail is the volunteer fire department generally does not respond outside of city limits unless there's confirmed entrapment, which there was. And so they were able to join us on this call.
Gotcha.
Which was really helpful for many reasons. They are not a medical department, so they're not even at a BLS level, but they do have extrication equipment. We have a good relationship with them, so
They know how
there's
to use it.
Yeah.
Cool.
Well, and we will get further into that.
Okay.
Because
Getting on all the good stuff. Okay, sorry.
So
it
when
was
your
an
partner,
extremely extended. Yeah, go ahead.
when the other crew says, "Hey, we're gonna take the red patient. We're getting out of here," and then now you're gonna arrive. Are they leaving? Are they the only asset on scene currently, or are there other people on scene and then they're gonna head out? Does that make sense?
Yeah, it does. So they were the only ambulance on scene. The fire department was between the ambulance that arrived first and me.
Okay.
If you all are following. So they arrived probably 5 minutes after the first on scene ambulance arrived.
So hang on, just so we're clear. The only emergency resource that was on scene took the red and left.
And so he almost did. We got on scene, and we had a small face-to-face from the window of each unit, functionally. And he reconfirmed the radio communication, radio traffic that he had already said, and then said, "Hey, we're just gonna take off."
Gotcha.
So Kyle, one more question. I apologize.
Mm-hmm.
So
No.
Any type of ICS structure out there?
Man, yeah, gosh, you all are just asking so many good questions. So that technically falls on the volunteer fire department. The hole in that is that they don't go to every scene, and they're not obligated to. And so when they aren't there, that generally goes fully unstaffed. We have talked about where we fit into that as a ambulance service, and it just doesn't work because we can't function as like a leadership member of an ICS system while also being like lead clinicians on a scene.
Right.
Yeah.
And so as you all know, and so it often goes unstaffed, and you just kind of have to grit through it. It does generally fall on the medic to coordinate a lot of those things while also providing patient care, as it did to me in this call. And we can go over. I mean, that's one of the major difficulties of that was this call because I was still learning the system. I'm still learning how to be a paramedic. Still am today. And a lot of these other entities, we had other law enforcement agencies on scene. We have fire department, and they're kind of looking at me for operational decisions as well as like I'm trying to figure out what the heck to do with these patients.
Right.
That's a lot of responsibility.
Yeah.
Sheesh.
But you've
yeah,
been
it was
out of
like
medic school now
it
by
was like
4
a-
weeks,
yeah.
so you're
Yeah.
fine. You're fine.
Right,
Okay.
right, exactly. Yeah.
So
Yeah.
let's go back to you've just gotten this update. These guys are 10 minutes ahead of you. You've gotten the update on how many patients there are and how they've
Right.
initially been triaged. Let's go back from that point forward and take us where you
Okay.
think we need to go.
Okay, perfect. So we'll fast forward to me getting on scene. I have a face-to-face with the other paramedic that's on. He says, "Hey, I've got the only red patient. He's sick. He's traumatically injured to a point where we just need to go." And so he says, "Hey, there's a yellow and 2 greens. You should be fine." And I go, "Okay, sounds good. Get out of here and take care of your really sick patient." And so he leaves. I continue 25 feet up the scene. The scene was spread out probably 200 yards, 100 yards. Well,
Wow.
let's say 100 yards.
Wow.
It involved a semi, an SUV with a family in it, and then one intoxicated driver who kind of caused the entire thing.
Mhm.
The intoxicated single driver was the red patient that he was transporting.
Okay,
So
one more quick
that
question.
patient, yeah, go ahead, yeah.
When he's
Absolutely.
transporting, or you're transporting, you're back there by yourself, right? So he's got a red patient back there by himself? Probably?
Correct. Yep.
Yikes.
Yeah, absolutely.
Okay.
Yeah, because we're a medic basic.
And there's no firefighters on
um,
scene that are able to jump in because they're doing extrication and mad respect right now.
Right.
Yeah.
You know what? No, Holly, that's an important question. So they might have, I can't confirm this, but fire, if they have personnel that will allow for this task, they can drive us.
Oh, cool.
Okay.
They're
Cool.
EVOC trained. And so I actually think, we'll say I'm 95% sure that they grabbed a fire driver and then he had an EMT partner in the back.
Okay.
I
But
think
still,
that's how they
that's,
played it.
that's
Still.
a lot, yeah.
It's a lot.
For 45 minutes.
Yeah.
Mhm.
Right.
Okay, go on, sorry.
And so no. Once again, it is helpful for me. This is like the most like fog of war style call I've ever ran.
Mhm.
And so in some ways it's easier for me to recall this when you ask questions because it was so overwhelming and challenging to determine the priorities of the call.
Sure.
That these detailed questions are helpful to keep me on track because it sort functionally, broadly, it felt like I was just sort of running around patient to patient,
Mhm.
trying to assess and determine what their needs were. So, but I'll get back to where I was. So they just took off with a fire driver, an EMT, and a paramedic in the back, taking care of presumably the most critical patient on that scene. And so I'm actually calming down a little bit, and I'm going, okay, great. 1 yellow, 2 greens. This is awesome. And we get on scene, and my quick triage immediately identifies an additional patient that he didn't report on. So we actually have 4 patients. One is red, and that is the patient that is still actively entrapped in the vehicle. And then we have 2 yellows that self-extricated. I would say one was bordering on red due to the RPM model that LT kind of already defined. And then we've got a green patient who has like some soft tissue injury that is like totally superficial, not concerning. And he actually ends up being really helpful because he is a really good historian to everybody's sort of history moving forward. So I'll give a rundown on the patient demographics really quick. The red patient that's still stuck in the car, that's grandma. She is between 60 and 80 years old. I never got much more than that. She is sort of squished. It's the classic situation where the whole dash and probably front of the frame is sort of squished up into her. And so she's trapped in a way where there's very minimal access to almost any part of her body. We've got 2 18-year-old women who are the yellows. One is still stuck in the vehicle. Actually, yeah, so I'll back up. They didn't self-extricate. One did, and one was actually still stuck in the vehicle upon initial assessment. One was laying on her back, supine, outside of the vehicle. And then we have the green patient, 45-year-old male, dad of the 2 daughters, son of grandma and her mom, who is still entrapped.
Who was the missing patient?
Grandma.
Well,
Grandma? Was unaccounted for?
I'm guessing. So I still don't fully know. I'm guessing what occurred because he said 1 yellow, 2 greens, and so I'm guessing he was saying grandma was yellow. The 18-year-old females were green, and I'm guessing he missed dad.
Got it.
That's my best guess moving forward. And so, but the way that I would, because my also guess is he did sort of a scene assessment and no actual clinical assessment. And that's how he was able to arrive at these conclusions. Because any form of clinical assessment immediately, identified these patients as 1 level more critical than he had tagged.
Gotcha.
And so yellow, was actually a red. The 2 greens were actually 2 yellows. And then we have this 4th patient who's identified as green. He really doesn't receive any form of meaningful assessment after that, like start triage RPM initially. He's
Which,
just sort
to
of
be
there
fair,
for
could be
the
a progression of their
majority.
illness too. Like they could be green, 10 minutes later they're yellow, 5 minutes later they're red.
Absolutely. Right. And I think that's a really fair point. Yeah, absolutely. And so, and not to mention the patient that he took ended up having bilateral tension pneumothorax, bilateral femur fractures, open wrist fracture. So, I'm like, you all know those patients tend to grab your attention and reduce your ability to like functionally describe other pieces of a scene well. And so I'm not, absolutely, Holly. I think that's super good point. Like, this other medic was distracted, and also, people can clinically change in 15 minutes. Absolutely. Which, and there's a high chance that that's exactly what occurred. And so, I'm having a really hard time at this point determining, frankly, who is. So this is another big challenge of this system is when these community workers respond, they aren't in uniform. And so, and I'm 3 weeks into this job, so I'm actually having a hard time trying to determine who is a lay responder, like flocking from their vehicle, and who is like someone who I can talk like lingo to and like trust to grab appropriate equipment from the ambulance. And so like this is kind of confusing me, all while trying to do an assessment. So I'll start with a red patient. Immediately, I found, so in initial assessment, GCS 15, but open femur fracture, active hemorrhage. And so, the fire department was very quick to say, hey, she's bleeding out of her leg. I can see her bone. And so that was immediately taken care of with a tourniquet and then a local pressure dressing sort of on top of that. And that bleeding was then controlled. That was the only part of her body that I had meaningful access to, which was lucky. And so once that was controlled and taken care of, I did its best of a trauma assessment. And once again, this is where I'm getting into pieces of the call that I would do differently knowing what I know now. And so if you all are thinking, wow, I would have done that differently, I 100% understand. Because pretty much after I controlled the bleeding and essentially confirmed that her mentation was like at an adequate level, and also realized there wasn't much more I could clinically do for her at the moment because she was so entrapped by the wreckage of her vehicle, I moved on to the person who was directly behind her, 18-year-old female, the most pronounced mid-shaft femur fracture I've ever seen that was closed. And so that was mid-shaft. It was like her knee and lower half of her femur are like displaced probably 3 inches from the other like superior part of her femur that attaches to her hip. And so Otherwise, she was DCS 15, actually, like emotionally really stable. So she was like probably she's probably top 5 most stoic patients I've ever treated, due to the fact that her family was in wreckage around her. Her femur's fully broken, and she's like so calm and so brave. And she actually helped me maintain composure on scene. So that's just like a patient interaction I will always remember. And I actually had a chance to transfer her later to a fixed wing unit at the airport, and talked with her more about that whole scene with her, because I was so impressed by her and her ability to maintain composure amongst all of it. And so
Wow.
that was a special part of the call for me. So either way, she needed obviously to be removed, and then like a more robust assessment to occur. And so I had an RN on scene lay responder who was badass. Edit that out if you have to, I guess. I go, and she goes, "I'm here to help." And I go, "Who are you?" And she was like, "I'm an ER nurse." And I'm like, "Here in this area?" And she goes, "No." I'm like, "Okay." And I'm like, "Are you down to put on a set of gloves and get dirty?" And she's like, "Heck yeah." And so we get her a pair of exam gloves, and she ends up being super helpful the rest of the call.
Nice.
And so I pair her up with a pair of county deputies and we have incredible law enforcement in the area. They are all first aid AED trained to the max. Like they really understand their scope of first aid and AED. Many of them have code saves via an AED.
Nice.
And so they are, as helpful as they possibly can be without having more formal pre-hospital training than just like what I was saying, first aid, CPR, AED. So, and so 2 county sheriffs were super helpful, along with this ER nurse and me, in terms of extricating this 18-year-old female with a mid-shaft femur fracture. We take her out onto a backboard, and then this is when functionally some of this on-scene MCI sort of physical sorting occurs. I am like kind of my mind works when things are like well organized. I'm as probably most humans, so I'm probably not unique in that regard. So, but I essentially started lining people up in row, like parallel rows next to each other, next to our ambulance. And so this particular patient went there, and I asked an advanced EMT who was also a community responder to come to partner up with this emergency room nurse and apply traction splint to this femur, and then complete a thorough, sufficient head-to-toe trauma assessment, and then come find me if there are any sort of glaring findings that need addressed. Because up until that point, my interaction with her had indicated that was actually like her femur was an isolated injury, and I wasn't super worried beyond that. And that turned out that it was, and there were no other injuries other than the femur fracture. And so I go back to the other 18-year-old. These are siblings. So I go to the other 18-year-old female on the scene. She's laying down. Her skin signs have dramatically worsened since the first time I saw her, and so she's laying down supine. There's a lady over her, sort of like sobbing, and I'm like, "Hey, who are you?" And like, are you a family member? Like at this time, I was still fully trying to understand like who all was there. And she sort of just like wasn't able to make words. And then I just I don't know how I came off when I said this, but I was essentially like, then I need you to leave. So then we can just like help her the best way we can. And so she just sort of like walked off. But that was just like a bizarre interaction.
That is bizarre.
Had. Yeah.
Was there like
and
traffic
so
backing up at this point, and people are walking around the scene?
Oh, for sure. Yeah. Well, and thankfully we had state police who were like more like, so we had deputies who were like engaged in the scene in terms of like almost patient care, and then we had state police like securing the scene,
cool.
which was great.
That's nice.
And so yeah, I just think like the people who were able to get in before they secured the scene, they didn't mess with. And so she was just like a straggler like you know how people try to help, but like they get immediately overwhelmed. And so it was like, hey, I get that like you're feeling all sorts of ways, like,
but I need
continue
you
to do that. Right, exactly, like 45 feet away.
Yeah.
And so and so she left, and then I'm like, was that a family member or anything? And this patient's like, I don't know who that was. And I'm like, okay. And
Nice.
so this patient reports like pain, like mild pain in her pelvis. And that's like it. And so
Why was
I'm
she
like,
just laying
oh,
there?
man.
Was she just too unable to get up?
So I mean, so like it turns out that she had a fractured pelvis and a splenic plaque. And so I'm guessing she was laying there because she self-extricated and then was like, this is really uncomfortable to move anymore.
Got it.
And,
I was just
and
thinking
so
that's a
she
bad
was just
sign
like there.
if she's just laying there.
Right, exactly. And it was. And so she is, I can't remember the clinical requirements or like guidelines between yellow and red, but like she was giving me like a mixture of yellow and red at this point, the way that she was presenting.
Yeah.
Right, exactly. She's kind of giving me an orange vibe. Yeah.
That's something you put over the air.
She's not red.
I don't know, Doc. She's more like an orange.
She's like orange. She's giving orange.
Yeah,
right.
I'm getting orange vibes from this one.
Oh gosh, yeah. And in fact, that reminds me, I need to like fast forward this because like there's a whole other part of this call that involves like the emergency room physician and like response. It's also kind of pertinent and juicy. And so either way, so 18-year-old that was in the car, sorted, getting treated. We moved the other 18-year-old that self-extricated that was found supine. We moved her next to her sister. Another like very vivid, lucid moment is I remember when we moved them next to each other, they immediately held hands. And held each other for the whole time. Yeah, so that's like if there's any benefit or reason to like bunch patients together, like that might be a good enough reason alone. Is to like give them like support during this trying period just by being near each other. And so that occurred. I asked an EMT, community responder, reserve EMT, to just get a set of vitals on that patient and do also a thorough head to toe. I then took this moment to go back to mid-shaft femur fracture and ask them how they were doing. They each look at me wide-eyed and go, hey, our traction splint, a hair traction splint from like 1990, broke while we were trying to pull traction. And so I immediately go, okay, buddy splint with the healthy leg, load her into the ambulance, and then like continuously take vitals. So kind of like was like, all right, if we can't pull traction, she's also in like 3 out of 10 pain as long as her leg doesn't move. And so I was like, just treat it positionally and then we're going to move on. And I'm going to go check in with the red patient that's still entrapped.
And the fire department is trying to get them out?
Yeah, the fire department at this time is just like mega struggling with all of their tools, trying to get this dash unfolded off of this person. It was about a total of 40-minute extrication time.
Are there any
So
other
it's like,
ambulances responding besides the helicopter at this point? Or is it just you?
There is the BLS unit shows up, and that's probably who started doing an assessment and vitals check on like pelvic fracture girl. All while I'm moving back to grandma and or mom, who is in the driver's seat of this car, I hear the rotors of hope.
The
like
rotors?
coming,
That is a... Wow.
It was seriously, I remember being like,
as the rotors turn, so
yes.
Oh, man.
Wow.
Yes, it was like so epically relieving because then immediately I go, oh, I'm gonna hand them the dumpster fire that is this red patient who's still stuck in this car, and I'm gonna focus on these other people. And so they do the classic. I mean, Holly, you know way more than I do about this, but they do the classic like investigatory spin or like 360 to determine their LZ, and then they land, and then they
okay, we'll land.
Right. They're like that looks really bad. Nope. No satisfactory LZ. We're clearing. No, thankfully they land. And they land, and there's like 80 cars in each direction, like watching them. Like it was a movie. Like the medic and nurse get out, they take their helmet off, like they're slow motion walking. There's like music playing in the background.
You got it right.
You know, like the nurse has like long, beautiful, wavy blonde hair. Like the medic is tall and bald and incapable. And, you know,
Wait, does he have a mustache?
No, he's
No
bald.
mustache.
He's bald. Everything is bald. Yeah, there's no mustache at all. But he doesn't care, and neither does the nurse. Like they are here to save the day, and I'm like, oh, sweet, sweet,
gosh.
sweet Lord, thank you for being here. And so I like trot over to them like this, like medic 3 weeks into the job. I'm like, hey, help. And they're like, okay, give us a scene report. I did. And I go, can I please just hand total patient care off to you all for this patient so I can focus on these other people? And they go, yes, absolutely. They show up to the car right as the fire department pulls her out and puts her on a backboard. And so I'm like, boom,
Perfect.
on a silver platter, there's your patient. I have done nothing except apply a tourniquet and a local pressure dressing to her femur, which is an open fracture. There's probably 750 mils of total blood loss, evidence of total blood loss, by the way, on the floorboard of the car. And so at that point, her mentation had changed to probably a GCS of 14. So like 15 and then to 14 when the flight crew showed up. And so I'm like half feeling
I'm like
okay
more
with how I
worried about
managed
your
that
pelvic
person.
fracture girl at this point.
Oh yeah, for sure. No, totally. And so this is where things get really challenging for me. And Holly, I'm so pumped. I didn't know your background. Actually, I didn't know Holly or Dan were going to be here at all. And so I'm like, this is like additional like
We literally do
awesomeness.
every episode with
I
you
knew.
guys.
And
Yeah,
Dan
yeah,
was a
right,
flight medic
right.
for how many years?
19.
19.
Oh,
Yeah.
that's right. I forgot
like a
about that
full
piece.
adult.
Okay, so right, exactly. I'm 28, so like,
Oh my gosh.
you know,
Baby.
I mean, I was born in '95 when.
Oh my goodness.
Yeah.
Oh,
Just to
Kyle.
like add to all of this. Yeah. And so actually, Holly, Dan, I have so many pieces to talk to you about with this because the flight crew goes, yeah, gotcha. Like they're super supportive. They get down to business, doing their thing. And I go and I start tending to these other patients. I asked this advanced EMT to try and get lines on both patients. She misses twice on the femur fracture, once on the pelvic fracture. We secure the pelvic. So this is before we had like commercial pelvic wraps, binders. And so this is where like my wilderness medicine background that I'm also like very involved in now. This is where I start kind of going into like wilderness medicine mode, and we like secure her pelvis with a blanket. And so we wrap that with a blanket, and then we buddy split. Also, the buddy splint thing is kind of from my wilderness medicine background as well. So we buddy splint the femur fracture. We wrap the pelvis. I go and I try and get a line on the femur fracture. I miss, and then as I'm sort of trying to determine like what the heck do these folks actually need versus what should we just do en route, I look back. The nurse has established 2 lines on the red patient, and the red patient is now totally unresponsive. And I see this medic kind of like grab a BVM and a mask and start just like begging her. I don't want to say hastily, but like with pep in his step. And I kind of see, and this is where like 2 flight clinicians, I'm so pumped you're here because this is where like I get distracted and I go, maybe they need some help. This is where like moving forward, I would never do this again because it turns out like they probably don't need my help. But when I walked over and asked, they immediately said yes. And so I would just not do that again and just stay with my people and not offer that, because though it was probably, I don't know, tantalizing potentially, maybe it wasn't, right? But I would just not open that door. And so either way, I walk back over and I go, hey, Do you want me to manage the airway while you're trying to do other stuff? And they go, yes, please, because she's about to code. And so I go, okay, I'm gonna drop an eye gel then, if she's about to code and there seems to be no gag reflex. I'm gonna assess for gag reflex and probably drop an eye gel. He goes, no, we're gonna tube really quick. We're gonna tube her really quick. And so this is where the most painful RSI checklist I've ever seen done occurs. Is where this nurse and this medic go and they're this medic or this nurse is super cheerful and positive, like golden retriever, but there's this patient dying, and so I'm I feel like y'all should be doing this faster, but I also get why checklists exist so you don't make mistakes. And they're very what seems nonchalantly going through their RSI checklist right as she's bradying down 40, 30, 20. And then I'm pulse check. And then the medic's oh, she coded. And so she coded while they're doing an RSI checklist. I drop an eye gel. We run the trauma code. And then during the trauma code, the advanced EMT that I'm working with goes, hey, do you want us to just load these patients up into an ambulance and go? And I'm you know what? Yeah, sounds good. So they load up those two patients that were the two 18-year-olds into an advanced EMT BLS unit, leave, and then code 3 back to the hospital. And then we run this trauma code that I probably should have never gotten involved in. Patient does not live. Black tag. They call their efforts quits. Call their medical director they brought up their stat phone. They called somebody. I assumed it was the medical director. And then I take off and we transport the green patient for a superior hand laceration. We go back to the hospital. So out of all of that, as the medic on scene, I transport the least critical patient out of all of them. And so that has always weirded me out. And
I've had the easiest
how would I? Right. So here's the deal. I didn't even take patient care. I drove. My EMT partner that was there took that BLS patient, and I just drove back and just and I was just wide-eyed, jaw open, what just
I mean,
occurred?
you managed the scene brilliantly because you wrote no charts and you took no. Yeah,
right. Seasoned
that is
veteran.
A 4-week medic right there. Seasoned.
Yeah, right. Yeah. Oh gosh.
I taught you well,
I will finish the story. Yeah. Even though you all never had me write charts when I was an intern. I never read it. Oh no, that's not true. I wrote some.
You wrote a few.
But either way. Okay, and then I'll finish up the story with we totally exacerbate and overburden our very, very small ER. When these kind of when we have more than 3 level 1 traumas come in, 3 or more, what occurs is all of the doctors in this hospital clear their schedule for the rest of the day and they just all flock to the ER. And so I was working with doctors I'd never met before. These are family docs that are just expected to respond when these large critical patient volumes come in. And so this is what occurs. And then the red patient that had been transported directly off the scene as I arrived, he ends up coding in the CT machine and dying. And so there was another helicopter heading to the hospital to fly him out. He died. And then the lead ER doc comes to me and goes, hey, that patient's dead. He's not getting a helicopter ride, but I'm still keeping the helicopter en route. Who needs to go? And so I go, this patient, I think. And it was the splenic lac. It ended up being splenic lac pelvic fracture patient. And so she flies, rotor out. And then mid-shaft femur fracture, I transferred to the airport for an airport transfer. What I remember feeling really bad for the dad about BOS patients, he gets pretty much immediately discharged. And then he sees his 2 daughters go in 2 separate directions. One facility was going east, flown. One facility admitted going west. And so he's essentially oh, here are my daughters.
Who's
going to 2 separate facilities. Yeah, right. For real.
You're not going to win that one.
So I'm ooh, that's a tough one. And so that was the scene. I have gone over this as like a training exercise with many people since, and I've also gone over it myself a bunch of different times. In some twisted way, I kind of wish I could run it again. In another way, I hope I never have to. But that is straight up as truthful as I possibly can be how that happened. And there are things I felt like I did okay, and there were many things that I would change going forward.
So Kyle, what would you change?
Yeah.
What would you change?
Yeah, thank you. So we have, and once again, like I said, we're 2 protocol sets more advanced now than when this call occurred. And so we have a much more advanced formulary now, particularly TXA being a drug change that wasn't an option then, that is an option now. And so for the red patient in the car, I would have done the classic like bilateral deltoid, 500 milligrams in each deltoid, TXA IM. And then after having controlled the open femur fracture bleed. And then I would have also done my best to find other forms of access. So I wouldn't have just like left her and just let her deteriorate in the car, essentially, which is what seemingly occurred. Like I would have been more active at treating her and checked back in with her more diligently. I would have also more quickly, probably more quickly decided to just get the mid-shaft femur fracture transported BLS, because she was vitally stable, isolated injury to her femur, and once she was buddy splinted, and that was like a position of comfort that could be maintained, she was in 3 out of 10 with no analgesia or traction splint. So I would have sent her much quicker down the road, and then probably prioritized my total care on the pelvic fracture and splenic lac. Once the flight service showed up, a flight service shows up, I never engage with that red patient again. I try and set them up better for success with, like I said, some form of vascular access. And then we leave. Exactly like an IO, or like maybe I'm able to just be craftier than I was and access a vein in an arm. She was pretty well crunched in there, but I felt like I didn't give that enough effort in terms of trying to be craftier with the care that the red severity patient received. And so those are some big things that I think about. And then I think about like the almost borderline arrogance a 3-week medic on the job needs to go ask a flight crew if they need help. I just wouldn't do that. And I would just trust that like their cumulative 40 years of experience probably is like that patient is in as good of hands as they possibly could have been.
But
so
they're looking at that going, oh, more hands, great.
Absolutely.
They're not looking at it going, oh, you
Me
you
either.
just graduated school.
Yeah.
They're looking at it as more hands. To
How long
help the
were you on
patient.
scene? At least an hour. Is that right?
Probably. Yeah. I mean, it was a 40-minute extrication alone, and then we worked the trauma code not too far after. I would probably say between 50 minutes and an hour. Yeah, total scene time.
I mean, like third party, I feel like you did amazing scene management. Like
Yeah,
you
me
ended
too.
up being the PIC on that scene. So you stayed
Thank you.
to watch all the patients leave. I really feel like if I could design it, I would design it the way you did it.
And being in the front seat driving back, that's a perfect place to be,
And then
because
you can tell
it's
the
all
doctor what
over.
you think happened. I mean, I don't know. I feel like you going with the most critical patient would have left the scene really vulnerable to know
and just chaotic.
completely chaotic. Yeah.
Yeah.
I think
It needed some kind of leadership.
Right, 100%.
Yeah.
And I think I don't listen to that. And again, I wasn't there, right? So we're armchair quarterbacking the heck out of this thing. But I listen to that.
Please do. Yeah.
I listen to that and go, okay, well, the first medic on scene should have stayed as essentially medical branch and ran the scene and then passed off that red to you guys right as you showed up. That would be the only thing.
That's a big recurring debrief point that gets made.
Yeah, because in theory, they're it. And you can, I mean, it was, from what you described, it was it was very close to abandonment. If they hadn't had made contact with you on their way out, window to window, that's abandonment.
Yeah.
I mean, you
It sounds
are
like
the
they
only
would have
resource on
gone
scene
whether
and you're
it's there
gone.
or not.
You know, can you imagine being those patients in the car
Oh, my
going,
gosh.
wait,
Oh,
what?
They're gone.
They're leaving, you know? I mean, what the heck?
Right.
at the same time,
Right.
man, I listened to what you did, and I don't.
I think it was
Sometimes,
amazing.
Yeah.
totally.
Yeah.
I
100%.
listen to that and go, oh my gosh, how many times are we in this profession thrown into a scene where, of course, we're going to look back and go, oh, I wish I would have done this differently. But you're the only person there,
Yeah,
right?
it sounds amazing.
You're
Jeez.
kicking
The only
butt
tiny
as best you
critique I would
can.
have is like every patient should have had an IO. That's the
Yeah.
easiest thing to do.
Yeah.
Immediate vascular access.
Word.
Yeah.
That's all armchair
yeah.
quarterbacking,
Yeah.
right? You're managing multiple
Please,
patients, multiple
yeah.
personnel, multiple everything. I mean, geez, just it sounds to me like I probably wouldn't have changed much.
Kyle, we don't usually have a case scenario that runs the entire length of the episode, but you have succeeded. It was a good
It was
one.
really
I'm gonna be
It was a
real.
really good one.
I actually knew that was gonna happen. I was like, okay, if they have an hour cap, like I'm gonna destroy this
Yeah.
hour cap.
We're there. Yeah.
And so like so yeah, sorry about that. But
No,
I mean,
this
not
is
only
great.
I'm a talker, but like this is just like it's just like a pretty big call for my
Huge. Yeah.
medic
Yeah, man.
career so far.
Yeah.
And it's one of those that but I super appreciate your all's kind words. I also just like as you all know, going into kind of the mental health aspect of all of this, it's like you all know, it's very helpful to talk it through with people who
Yeah.
get it, who work
Mhm.
in the field.
For sure.
At first, like it really bothered me how things went. I've since come out of it to a place where it's like, sometimes calls just are really confusing and hard. And you do the best you can at that time and you move on. And then just like you all three of you have said this at one point during this podcast. It's like as long as you can gain some form of knowledge and wisdom and like learning from it and move forward, then you're good. And so that's sort of how it's felt. Interestingly enough, like going back to the kind of MCI vibe of this episode and of this call, it is not hard to run into an MCI at this system. A few have happened since, nowhere as severe or critical as this one. But yeah, it's something that I have actually had to get used to, just because, big rural area, very, very like high traffic rural highway, for commerce, business, shipping, kind of goes through here. So we have big like MCI style MVCs happen all the time. And so,
That's good awareness, because
fly a lot of patients up.
if I ever roll up on scene, I would never get out and be like, can I help you?
Right.
Yeah.
But in that case, and that may be a really rural area, if you do have some skills, maybe I love how the bystanders kind of came out of the woodwork to help you
Right.
out. That's really cool.
Oh, totally. Yeah, that ER nurse was awesome. Like she was great. And sometimes like we do have a lot of labor responders in the area that I work in. It's just sort of like a little bit of a cultural thing. And so not to mention like there are so many people from so many different areas of the world that kind of come through. And so it is not the first time I've had a labor responder, and I always give them the same spiel where it's like, are you actually willing to help? Like crawl in, and like we are not responsible if you like cut your knee on glass, like if you get exposed
Sign
to
this
blood. Like
waiver.
I'm
Yeah.
like, right, kind of exactly. I'm like, if you are actually going to help, then like full blown like welcome aboard. But like I'm not gonna like throw you the easy stuff. Like if we need your help, like we're just going to ask you to do whatever. And so some of those people are like, let me go back to my truck and blah blah blah, which is like I'm actually not interested. Or some people like this ER nurse, she was like ready, and it was super helpful.
Yeah.
Just her energy and willingness alone was, a big gift. So
That's right.
yeah.
Well, Kyle, thank you so much for. Dang, man, what an incredible call, and so many learning lessons in that
Yep.
one. I truly think it's the ones where we feel like the most mistakes have been made are the biggest opportunities for learning, and they shouldn't be viewed as a bad thing, but rather an opportunity for everyone to get better. So thanks for sharing your story, and thanks for reliving it with us. And happy to have you on the show, man, and would love to have you back on at another time.
Cool. Yeah. Thank you, you three. I had a fun time. I hope listeners get something out of it.
Totally.
Yeah.
Awesome. We'll leave it there, and we'll catch everybody on the next episode. Thank you.